Hello, and thank you for joining this OncLive peer exchange titled Immuno-Oncology in Advanced Lung Cancer. We continue to see extraordinary progress in the treatment of advanced non-small cell lung cancer, with paradigm-changing research being completed at an astounding rate. In this OncLive peer exchange discussion, I am joined by some of the world's leading experts on the use of immuno-oncology agents in patients with lung cancer. Together, we will discuss the latest data from the ESMO 2017 meeting and explore the nuances of using checkpoint inhibitors in your patients with advanced disease. I am Everett Vokes, John E. Altman Professor of Medicine and Chair in the Department of Medicine and Physician-in-Chief at the University of Chicago Medicine and Biological Sciences. Participating today on our distinguished panel are Dr. Roy Herbst, Professor of Medicine and Chief of Medical Oncology at the Yale Cancer Center in New Haven, Connecticut. Dr. Fred Hirsch, Professor of Medicine and Pathology at the University of Colorado School of Medicine in Denver, Colorado, and the CEO of NSCLC. Dr. Suresh Ramalingam, Professor of Hematology and Oncology and Director of the Division of Medical Oncology of the Winship Cancer Institute of Emory University in Atlanta, Georgia, and Dr. Naiyer Rizvi, Professor of Medicine and Director of Thoracic Oncology at Columbia University Medical Center in New York, New York. Thank you very much for joining us, and let's begin. And we'll turn to our first segment, which will cover immunotherapy in non-small cell lung cancer, the transformation of upfront management. And here we're going to talk very much about the historical perspective, how treatment for non-small cell lung cancer has evolved over the last 15, 20 years. From the beginnings where chemotherapy was questionable, chemotherapy then got established, first line, second line, and eventually targeted therapies came along, and now immunotherapies are coming along. So as we look at patients who don't have driver mutations, and those who have squamous cell histology, but also others, how do we look at their treatment now, and how have things changed over the last 5 years? And Ram, why don't we begin with you?
Sure. So now we have immunotherapy in the first line space, but before that, going back about a year in the clock, we had patients non-squamous histology undergo molecular testing, and if they had a driver mutation EGFR, ALK, or ROS1, they got targeted therapy. And if they did not have a driver mutation, they got platinum-based chemotherapy with or without bevacizumab for non-squamous. And in squamous histology, we used platinum-based chemotherapy. Molecular testing in squamous was only for those rare patients who were never smokers where there's possibility of EGFR mutations. But for vast majority of these patients, platinum-based chemotherapy. The targeted option there was necitumumab. It's still approved in the frontline setting in combination with chemotherapy for advanced squamous cell. And this has been the treatment paradigm, and then patients went on to second-line chemo. 2 years ago, we had second-line immunotherapy. Now, of course, we're going to talk about how immunotherapy is integrated into the first-line setting.
Very good. And for that, it is all recent data that have come. And we should, as we move forward, talk about that a little bit. So anything you want to add to that, Naiyer?
Yeah, no, I think that, chemotherapy, in the era of chemotherapy or even targeted therapy for a patient who had advanced lung cancer, it was really hard to offer them a lot of hope, and then I think that, you had a really finite benefit from these therapies. Everyone developed resistance. And I remember the first patient I treated with PD-1 antibody, even with nivolumab, he had been multiply pretreated. He showed up in clinic with a painful adrenal mass, and it was so painful that after he got his nivolumab infusion, he had to go to the emergency room for IV pain medication. He woke up and he was pain-free, and now it's, 2009? It's 8 years later, and he still has no evidence of disease. And that's why I think we're so excited about incorporating immunotherapy into our treatment.
I think that's very correct, and those are stories we never talked about when we were giving chemotherapy. I very similarly remember the first patient where I stopped pembrolizumab after 2 years because that's how it was written, and when the drug was still investigational. And of course you have all the fears of doing that, and yet it is now again 2 years or 3 years later, and that patient is doing well.
Right.
So it's transformative.